About two important aspects, which is robustness and fairness in the context of clinical AI. So these models, when they are developed, they are basically fine-tuned to high accuracy, right? But when they are deployed, we see a lot of variations in the data. For example, there can be noises, right? Noises of different kind. I'll briefly talk about it. And there could be, bias in the data. Bias meaning, when you develop the model, the data was predominantly collected for a particular kind of subgroups, right? So I'll be mostly talking around these two things, and rather than going deeper into the how AI handles that, because I think once you understand these issues, then it is, there are enough models to, take care of these issues. So one major issue in the data, in the clinical data, is the noise, and noise happens at various levels. So right from the, the patient to the EHR level. So at the patient level, there are, when you are collecting the data, so there are, motion artifacts. Because of that, your recordings can go wrong. And there are hardware factors. So machines are old, sensors have gone bad, or, the different machines come with different calibrations and so on, right? There's also annotation subjectivity. Different radiologists are trained and experienced in different way. And so again, I'll be going a little bit more into that. So first one is the hardware and acquisition noise. So I don't intend to say that Philips machines are bad, but different machines, different manufacturers, they have different, their machines have different calibrations, right? And the algorithms in the backend, what they used in the machines, right? They are different. So finally, if for the same patient, if you get the scans from different machines from different manufacturers, you will see different data, right? That brings a lot of variability and noise in the data, right? Even in the single machine, there are a lot of algorithms in the backend, like the filters that you use in the CT, for example, depending on the smooth versus sharpness, the final image texture would be different, right? So and the hardware edge, of course, with as the machines are becoming old, their sensors are going bad, and they slowly perform bad, and the scans that you are looking at, are getting through these machines are of not that same quality, right? This is the another example of noise, which is the physiological artifacts, the human factors. So basically, when the a person goes for a scan, there are motion artifacts, right? So like in there is a lot of blurring that you see in the first image, or in the second image you see the ghost effects, right? Even when you take X-ray, many people don't remove off their jewelries. So in the scans, you will see the jewelries, or rings here and there, they are coming up in these scans. So finally, that is also your data, and then it is different from the regular, right? So this is again kind of noise because of these issues. Another the reason for the issue is the anatomical deviation. So different people have different physique and anatomy. So that also brings a lot of variations in the data, right? Finally, when the radiologists, they label the data, there is a lot of variability into that. For example, the variability in the lung nodule classification. There's 35% of the radiologists, they disagree on certain the images, and I mean the final classification. Not even that, even a single radiologist, this for the same kind of data, their variability is 15%, right? And why is that happening? It's because of various reasons depending on the experience of the radiologist. There is clinical fatigue, and there's reporting time pressure. So there are a lot of issues, and these are all practical issues. So because of that, there is a lot of such noises are coming into the clinical data that we observe. So this is one example. Again, this is just generated by the one of the GPT. So like this is the tumor segmentation, and there are 4 different radiologists. They are drawing different boundaries. No 2 radiologists have same boundary drawn, right? So there is again a lot of variability coming up into the data. Then so all these things I have mentioned. Then coming to some of the measurement errors, again, the different machines have, all of the machines use some kind of sensors, and the sensors have their own measurement errors, right? So some of the common noise that occurs in these measurements in different kind of machines are different. So for example, in the CT or MRI machines, there is some Gaussian noise. Again, I'm not going to explain that, and it's fine. There's different kind of noise. And in X-ray and PET scan, there is another kind of noise. So there is some systematic noise which is happening in the measurement in all these different machines, right? So this is another source of noise. Then the final, the another level of noise, which is in the administrative level, when we create the EHRs, right? At that level also, so for example, because of the hospitals as well as the patients as well as healthcare providers, they are you also want to get the insurance claims to be reimbursed, so you want to emphasize too much on the health issue, the more than what it is, right? So that creates a noise, that you are not putting the actual ground truth in the EHR reports, and I'm sure many standard hospitals don't do that, but there are many hospitals which do such malpractices. So that brings a lot of non-random errors, which is strong bias which is coming into these EHR reports, and many times in a hurry of writing, there is the hospitals are already overloaded in India, and so many patients, and also even for every task there are long queues. So every task you have to finish in so early. So many times you don't report many of the clinical observations into the reports. That also brings, so basically you are not reporting something that is also some kind of noise, right? Then there are data duplication issues and all these kind of things. So basically, there are in the clinical data, there are multiple layers at which the noise is coming up, and so when we build any AI model using that, we see the model is not doing as good it was supposed to be, right? We do see there's a lot of accuracy drops, right? So just one example. So as the noise level is increasing, so from 0 to 30%, there's not just the model, some AUC is one metric for the performance, which is dropping, but even the biomarker detection rate is also decreasing a lot as the noise is increasing. So when we see these images and you are missing out something, okay, there's no issue, But that's because of all these noises which are there, which are not being taken care well in the model building, right? So it is very important, especially in this clinical AI setting, where you should be, we should be using more robust model. Of course, for every different kind of noise, there are different kind of techniques to handle it, right? So then I'll jump to the second major issue in the clinical data, which is always not looked at as as seriously, just the bias issues in the clinical data. So so there are two main issues because of which this bias is coming into the data. One is the selection bias, right? So most of the data that we have is from the people, who can afford the healthcare in a good hospital, right? Not all people can afford such a luxury, So then there is definitely a selection bias. We have data from mostly from the urban areas, and who are doing financially, they are doing well, they can afford the expenses and all. So we are lagging the data from a major chunk of the society who cannot afford such facilities, right? Then there are measurement bias. So many of the tools, even many of the measurement tools, oximeter and all, we'll come to those examples, which have strong bias towards certain group of people, so then there are issues coming because of that. So there are multiple ways this data bias is happening. So that brings a lot of unfairness into the model prediction, right? So for example, this pulse oximetry, so I'll be just reading the first statement. So this is relying on the light absorption through the tissues, right? And for the people with black skin tone, it always reports higher SpO2 compared to the people with light skin tone. So even if the black skin person is suffering from low oxygen levels, this pulse oximeter will say, yeah, he's fine, SpO2 levels are fine, nothing to worry. Now imagine in the COVID kind of situation, people are assuming, oh, I am doing fine. They are using this pulse oximeter at home. Okay, I am fine. This is not the issue. But actually the issue is there, right? So the tools are also not good, right? So this comes at the measurement level. The second kind of issue in the bias in the data. The another example is the when you are finding out how the kidney is functioning, right? So there is this equations that people use. I also came to know yesterday when I was doing research on it. So calculating the kidney function, it included some biological race multiplier. So for black people, that factor is different compared to the light skinned people. And what it says that it even if their kidney is not functioning well, their score is high, which means the kidney is doing well, right? Imagine, who designed it, we don't know, but that is into the practice, right? So that is not being taken. I don't know whether it is being taken care or not, but I just came through it yesterday. So there are these kind of issues, one at the measurement level, then even we are using some models to generate scores for the how the organs are functioning. Those equations have bias towards certain group of people. Again, this is another example for dermatology AI. So the two AI models for melanoma detection, the data sets that they use are mostly the most of the data is from the light skinned people. So 90% of the data is from them. So very small representation from the black skin tone people. Right? Now imagine that model is highly tuned for a particular group of people. So if it doesn't represent well the other group of people, there is no guarantee it will do well in the real case, right? So as a consequence, they don't get proper treatment, the other group of people, whether they are financially well or not, but just based on the skin color, certain tools are not doing good, and they are detected, they are healthy, no issue, go home, and they don't get treatment, right? Then, of course, the financials are always, again, that's the first thing, a person who can afford the medical facilities, their health records are maintained in the hospital. The person who cannot come to their health records are not maintained. Simple, right? So that again creates bias, because all the models or even the research studies are conducted based on the data which is available. For the people for whom we don't have the data available, we don't know what health issues they are going through, or are there any different kinds of complications coming up in general, right? So we are not aware of that. So even the research is driven by the data which is available, and the data is available for the people who can afford the costly medical facilities, right? Okay, so of course there are a lot of models which can handle the bias, bias in the data and the noise in the data, and there are tons of models and which are doing well. But I think it is most important to understand at the level of data analysis whether, before building the model, it is very important to understand whether there are such issues there, whether there are noises or there are bias issues, and then we should be taking appropriate measures towards that so that people don't suffer, because this is very high risk kind of setting where even a single person doesn't get proper treatment. It's a high risk, right? So the robustness of the model is equivalent to safety in the clinical setting, right? Because of they are not robust, they cannot because of the noises, if you are missing out, then the people are not safe in the clinical setting, right? And fairness is justice, because you're not doing it intentionally, but the models are not designed well, and because of those bias issues, if the model is not able to detect a deceased person, then it's injustice to that person, even if the person can afford the cost, right? So the key takeaway is that the accuracy of the models should not be the only metric when we are deploying them in practice. These two things, there are other factors also, of course, but these are the important factors which should be considered while deploying the models in clinical diagnostic setting. So with that, I will stop, and apologies once again for my again.